Dear Professor, dear colleagues, I'm Dr. Mohamed Ali, lecturer of internal medicine at Shams University. I'm talking about new onset and relapsed renal pathology with COVID-19 vaccination. Our agenda will be COVID-19 pandemic, health and economic burden, COVID-19 and CKD, mechanism of action of COVID-19 vaccines, type of COVID-19 vaccines, and finally, post-COVID vaccination, glomerulopathies, and renal pathology. COVID-19 pandemic, health and economic burden. The COVID-19 disease pandemic has a huge impact on health and economic because of its rapid spread and multiple mutant variants since 2020. The spectrum of including ARDS and acute kidney SARS-CoV-2, the etiological agent of COVID-19, between its spike protein and ACE2, thereby inducing the systemic inflammation or dysfunction by activating the nuclear factor kappa beta associated inflammasome and producing a downstream cytokine storm. The high-risk group for SARS-CoV-2 mediated critical illness includes those with obesity, diabetes, advanced age, and CKD. Among these patients with critical illness was higher than the impaired immune system in CKD patient and undergoing kidney transplantation. Given that there are no curative solutions currently available to treat or prevent COVID-19 manifestation and mortality, the introduction of vaccination program following the discovery of COVID-19 vaccines, in addition to the public health infection mitigation measures, are the main strategies to reduce the COVID-19 numbers. Currently, the techniques for SARS-CoV-2 vaccines include targeting inactive SARS-CoV-2 vector carrying the nucleic acid for spike protein, attenuated virus, protein fragment for SARS-CoV-2, messenger RNA for SARS-CoV-2 carried by lipid microparticle, or the DNA sequence carried by adenovirus. As regards the COVID-19 pandemic and CKD, SARS-CoV-2 enters the host cell via ACE2. ACE2 interact with 1 and 47 by facilitating the entry of SARS-CoV-2 into the host cell. In CKD patient with diabetes in home, the activity of RAS is often not altered by RAS inhibitors. In a study by Awadish et al., titled "The Prevalence of Comorbidity and Their Association with Mortality in Patients with COVID-19 in 2020," the prevalence with severe COVID-19 was up to 4% in CKD patients. Another study by Kai et al., titled "Mortality in Chronic Kidney Disease Patients with COVID-19," the odds ratio for mortality in CKD patient was up to 5.81%. This study by Ganzoforti et al. Uses the Open Safely Health Analytical Platform from more than 17 million people. These are higher risk than those with other COVID-19 SARS-CoV-2 infection. An analysis of multiple databases demonstrated that the comorbidities mediated by SARS-CoV-2 infection might contribute to the higher incidence of AKI in COVID-19. The contributors to recovery of AKI in SARS-CoV-2 were limited to survivor of SARS-CoV-2 infection. The most common kidney biopsy finding associated with COVID-19 infection are acute tubular damage, collapsing granulopathy, and thrombotic microangiopathy. There have been few glomerular disease associated with COVID nephropathy, membranous nephropathy, and lupus nephritis. In addition, there have been reports of mixed pathological renal disease, acute interstitial nephritis, and treatment-related AKI in COVID-19 patients. What about mechanism of action in COVID-19 vaccines? The main aim of COVID-19 vaccine is to establish immunity to the spike protein of SARS-CoV-2. For human and mice, immunity to the S protein could be induced by exposure to the full length S protein and the extracellular domain of S protein. A viral vector with an expression and receptor binding domain for the S protein served as a strategy for developer. The S protein of TOR2 and SZ with high affinity of for the receptor binding protein of the S protein. This is only two, but a lot of vaccine type available. But we could talk about mRNA vaccine such as Pfizer and Moderna, vector vaccines such as AstraZeneca and Janssen, individual receiving virus between CD8 and CD4 expansion, and the type 1 T helper cell-based response and production of interferon C, tumor necrosis factor alpha, interleukin 2, and immunoglobulin G1 and G3 subclasses. Lipid nanoparticles and nucleoside modified mRNA encodes the spike protein. Also occurs early, as Mohamed Ali EZZAT between 3 and 4 days after vaccination. Another studies by Lebedik et al. And Leclerc et al. Used the time interval between 4 days and 4 months after vaccination interval to see the symptoms. This study by Henry et al. In 2020 showed the cases reported by minimal change in disease after COVID vaccination. It usually occurs after the first vaccine dose. And the outcome was resolving of proteinuria, and the patient may follow the dialysis independent program. What about IgA nephropathy? IgA nephropathy, it has been reported that severe COVID-19 infection is associated with an increased level of IgA and antiphospholipid IgA antibody. This association, which is probably triggered in the bronchial mucosa, may have a role in the systemic complication and autoimmunity in a patient with COVID-19 infection. Likewise, the receptor binding domain of the viral spike protein is highly specific target for neutralizing antibody in COVID-19 patient, which suggests that the presence of an association between them. Most of the cases mentioned in the literature review were relapse of original disease rather than new onset disease. The exact underlying pathology or pathogenesis of IgA nephropathy following COVID-19 vaccination is unknown. Baring et al. Suggests that the IgA cases following COVID-19 vaccination seems to be unrelated to the anti-SARS-CoV-2 antibody response. Rahim et al. Suggested that the IgA nephropathy flare following the second dose of COVID-19 vaccination may be induced by a delayed type of hypersensitivity reaction. Kudus et al. Suggested that the immune response to vaccination with the systemic cytokine IgA1 anti-glycan immune responses. The mRNA vaccine, similar to COVID-19 infection, produces strong antibody. Therefore, the glycosylation of the receptor binding domain and the immune response from the mRNA vaccine may be the underlying cause of production of antibodies that result in the deposition of IgA immune complexes. Et al. Suggested that the development of IgA nephropathy following COVID-19 vaccination may be due to the production of anti-glycan antibody in this patient with IgA1. Also, this paper by Henry et al. Showing the patient with the IgA nephropathy following post-COVID-19 vaccination. It usually occurs after the second dose, and the outcome was resolving of hematuria. ANCA-associated vasculitis. Recently, ANCA-associated vaccines the patient 4 weeks after the second autoimmunity, production of autoantibodies, and autoimmune disorders. The mechanism may be due to some receptors that bind and pro-inflammatory cytokines, which are associated with autoimmune disease, and by activating the transcription factor, nuclear factor kappa beta, the production of type 1 interferon and interleukin 6. The exact pathogenesis of the ANCA-associated vasculitis following COVID-19 vaccination is still unknown. Sekar et al. Suggested that neutrophilic immune response to mRNA vaccine that occurs after the second dose. Andrig and Shakor et al. Suggested that the trigger in predisposed individual may be an immune response to spike protein or mRNA of the COVID vaccination. However, further investigation regarding the exact cause of ANCA-associated vasculitis following COVID-19 vaccination are required. What about primary membranous nephropathy? Membranous nephropathy has been associated with various infectious diseases such as hepatitis B, C, HIV, syphilis, and hydatid. FLAR2 is a major target antigen in membranous nephropathy, which is also present in the respiratory tract. Therefore, they suggested that this could be a potential source for antigen presentation to induce or reinforce autoimmune response against FLAR2. A small number of reported cases of primary membranous glomerulonephritis post-COVID-19 vaccination are mentioned in the literature. One of them mentioned by Aiden et al., who reported a relapse of membranous nephropathy in a 66-year-old female patient following the Sinovac vaccine with development of nephrotic syndrome. After excluding of the secondary causes, okay, so the speculation regarding whether the mechanism of immune system dysregulation following the vaccination triggers this presentation is available. What about anti-glomerular basement membrane nephritis? The exact pathogenesis of anti-GBM nephritis following mRNA vaccination is still unclear, although it has been suggested that it may be due to an immune response to the vaccine. The number of reported cases of anti-GBM nephritis post-COVID vaccination is small. One of these cases reported by Tan et al. As the patient presented a day. Another case by Obid et al. 2 weeks after the second dose of Moderna. Both of these patients developed AKI and were treated with pulsed methylprednisolone, cyclophosphamide, and plasma exchange. One patient remained dialysis dependent at the time of report, while the clinical outcome of the other patient was not reported. Further studies are needed to investigate the cause of this association. About acute tubular interstitial nephritis, the development of acute tubular interstitial nephritis is suggested to be caused by a T lymphocyte-mediated injury with an apparent innate and consequent acquired immune response. Ingredients found in the COVID-19 vaccines, such as mRNA and polyethylene glycol, are known to be immunogenic agents and induce delayed hypersensitivity reaction. Some acute TIN cases after COVID-19 vaccination have been observed and responded well to steroid treatment. De La Flor et al. Reported a case of acute tubular interstitial nephritis following COVID-19 vaccination with Pfizer. However, it's worth mentioning that this patient was using drugs such as allopurinol. However, the association of acute tubular interstitial nephritis following COVID-19 vaccination requires further investigation. About TMA, the pathophysiologic mechanism of TMA after COVID vaccination have not been yet clarified. A case of TMA have been reported by Defibritis et al. After Pfizer. In this case, foamy urine was observed 5 weeks after the second dose of vaccination, and the complete remission was achieved after steroid pulse therapy and high-dose steroid therapy. As in the case of TMA after influenza vaccination, complement activation by immune dysregulation is presumed to be involved in its occurrence, and the T lymphocyte may be an important mediator in vaccine-related TMA. About scleroderma, renal crisis, and the flare of lupus nephritis, there is a case reported following mRNA diagnosis and pre-existing diffuse cutaneous systemic sclerosis. A flare-up of lupus nephritis have been also reported after COVID-19 vaccination. Tashan et al. Reported a patient first dose of Pfizer vaccination. She was a known case of lupus stage 5, class 5 lupus nephritis in a remission who was receiving hydroxychloroquine maintenance therapy. What about the relapse of IgG4 related disease nephritis? To our knowledge, there has only been one report of a relapse of IgG4 related disease nephritis following COVID-19 vaccination by Masset et al. Masset et al. Suggested that there is a possible link between the relapse of immune disease following mRNA vaccination. However, it is still unclear whether the relapse are due to a direct immune activation triggered by vaccination or due to a chronic immune activation triggered by allergic reaction. The pathogenesis and the association between IgG4-related disease and the COVID-19 mRNA vaccination require further investigation. Take notes. mRNA vaccines appear to be the most frequent COVID-19 vaccines associated with, just 1 minute, a vaccine associated with post-vaccination kidney disease development. The higher number of the fact that the vast majority of the cases were reported from a selected number of countries where Pfizer and the Moderna have been more accessible and commonly available in established vaccination program. The real frequency of acute kidney impairment following COVID-19 vaccination as a result of inflammatory complication may be underreported in literature. We do recommend vaccination for everyone being excluded from all major trials and data on vaccine efficacy, as Dr. Sherry said, particularly safety as regards relapse and recurrence risk, and specific adverse event will only become available during the ongoing pharmacovigilance study. The Center for Disease Control clinical guidance states that immunocompromised individual may still have no contraindication to vaccination. However, they should be counseled about the unknown vaccine safety profile and effectiveness. And the effectiveness in immunocompromised population, as well as the potential for reduced immune responses. The potential for COVID-19 vaccine to induce immunity protecting from severe COVID-19 should overweigh the potential risk in most cases. Last question. Do you prefer giving COVID-19 vaccines to all CKD patients from your clinical practice experience? And thank you.